will be presenting on the New Jersey immunization requirements and providing you some information on some of the initiatives and the resources that we have developed. As you know, immunizations is a shared responsibility from statewide to local agencies. It requires collaboration between various stakeholders, such as our healthcare workers, local health departments, our community-based organizations, such as schools, including our child care and preschool facilities. And obviously, we know that the first point of interaction happens between the parent and the provider, but after they leave the doctor's office, like when is the next time that they'll be able to get vaccinated or to be reminded of that they need vaccines? And so it's important that we all work together. So whether they're the local health departments provide immunization clinics, or community-based organizations such as FQHCs would provide immunization clinics, and the school should be reminding children of what they need to be in compliance with New Jersey school requirements. So I'm going to go over those requirements a little bit later in this presentation. But just to start off, I wanted to just discuss New Jersey's vaccine preventable disease program. Our mission is to reduce and eliminate the incidence of vaccine preventable diseases affecting children, adolescents, and adults by raising immunization coverage rates of New Jersey's citizens. Our VPDP consists of multiple component areas to assist and collaborate with our local partners to achieve these goals. And so I'm going to highlight some of these component areas more in detail in the next couple of slides. So one of our major component areas is the New Jersey Vaccines for Children program, or also known as VFC. It is a federal entitlement program that provides vaccines to those who are uninsured or underinsured and under the age of 18. We also have the discretionary funding program, also known as 317, which provides vaccines to adults 18 years of age and older. So just to point out, currently the COVID-19 vaccine is offered through the 317 Bridge program. However, that Bridge program is going to cease in August of 2024. So then you will have to just resort to the VFC and the regular 317 program. We also have our New Jersey Immunization Information System, which is our statewide immunization registry. It's our official statewide registry. It maintains immunization data on New Jersey residents across the lifespan and provides a consolidated immunization record. Since 2011, New Jersey has had a mandate in place for all providers who administer vaccines to children under the age of 7, so 6 years of age and under, to enter the immunization information into the registry within 30 days of administration. So that law has been in place for some time, and so we do remind any providers who has not currently actively been entering into the registry to please do so, because just like any other licensing requirement, this too is a licensing requirement for the providers. We also have, during COVID, we created we are working with Docket, which is an app that connects you directly to the New Jersey Immunization Information System to deliver your up-to-date personal and family immunization records. You can use the Docket app to provide proof of vaccination status as needed for school, work, travel, etc. But Docket is a tool that we can that can serve as a cue to action to keep on track with routine vaccination. So if you're due for a vaccine, it's a good way of being able to track that. And then BPDP supports multiple health service grantees throughout the state, including 2 coalitions. One is the New Jersey Immunization Network, also known as ENGINE, and the other is the Essex Metro Immunization Coalition, or EMIC, which is where we're at right now, to help improve immunization coverage rates by utilizing best practices and providing education. ENGINE, like I said, is a statewide coalition jointly co-founded and led by the New Jersey chapter of the American Academy of Pediatrics and the New Jersey Academy of Family Physicians. And as you all know, EMIC is a municipality-focused immunization coalition representing the greater Newark, East Orange, Orange, Irvington areas, all of which are pocket of need areas. And so we rely on our immunization coalitions and our community partners to promote timely and age-appropriate immunizations to decrease vaccine-preventable diseases and improve the overall health of our community, of the community. Moving on, evaluation is a key component of continuously assessing gaps and identifying targeted areas of need. And this is tied to the population assessment component, which is my component area. We use the following evaluation tools to assess New Jersey's immunization coverage rates. We heavily rely on the CDC's National Immunization Survey data, or NIST data. We also look at the New Jersey Behavioral Risk Factors Survey, the National Health Interview Survey, our annual immunization status report, which is it's a self-report submitted by the schools. I have approximately 6,400 schools, 6,300, I should say, in the state of New Jersey, including childcare and preschool facilities that have to submit to me on an annual basis. I have a reporting rate of almost 94%, so it's a good representation of what the immunization status of those students are here in New Jersey. We also have our local health department immunization audits, which the health departments conduct to validate what was submitted by the schools in their status report. And then we also have our New Jersey Immunization Information System, also known as NJIIS. So I just wanted to provide a brief overview of what our rates look like before we go into the actual vaccine requirements. On this slide, based on the vaccination coverage estimates obtained through the CDC's NIST survey, indicating coverage for children 24 months of age born in 2019 to 2020. So you can see that most of the recommended childhood vaccines has remained high and stable. And New Jersey's coverage is similar to the national. However, there is some the rates are lower, I should say, in the combined 7 series, which is right here. You see right here. So we're at 64.2%, and the national is 69.1%. And we also have lower rates in our pneumococcal vaccine for 4 more doses at 75.7% and 82.7% for a national. So we do think there is some work to be done. We know for a fact that the pandemic had an impact on our coverage rates and across the nation, not just New Jersey, but across the nation. So there is work to be done. And it's just a matter of I'm like losing my thought here, sorry. Oh, that's what I wanted to say. So yes, the rates are a little bit lower and we're rebounding, but we have to keep in mind that the NIST data, the NIST survey is, the CDC NIST survey is a random digit dialing survey where the sample size is really small. It's around 400 and 400 children in the sample, and they make sure that, if the parent agrees to be surveyed or to respond to the survey, that they can also validate that information with their healthcare providers. So the sample size is really small. It's only 400, like I said. And you also have to keep in mind that none of these children in the sample may or may not be attending school, so they may not be obligated to get all of the recommended vaccines. Even though that they're recommended, they wouldn't be required for them. So we have to keep that in mind, as where my status report, which is submitted by the schools themselves, they're reporting, and like I said, I have a reporting rate of almost 94%, and I have a sample of almost 6,300 schools in New Jersey. And so we have to just keep that in mind. And then this graph here is just showing coverage trends from 2016 to 2020 for the single antigens, along with the combined 7 series, which is illustrated in the blue on the left, in the graph on the left on the bottom. And so increases were observed for MMR, hepatitis B, and varicella. The combined 7 series, unfortunately, has steadily decreased each year. In 2016, the coverage was around 68.3%, and then in 2020, it dropped to 64.2%. So of course, we don't want this downward trend to continue, and so therefore we do have some work to do there. I think that's it there. And then on this slide, this slide shows the most current adolescent immunization coverage rates, similar, and the coverage rates are very similar to the national rates from 2022. As you see, meningococcal and Tdap rates are high, and then the HPV rates, not just in New Jersey, but throughout the nation, our HPV rates have some more work to do. Like, there's a lot of initiatives taking place to help improve HPV throughout the nation, including New Jersey. But one thing to keep in mind here, the reason why our meningococcal and Tdap rates are high is because New Jersey has a mandate for meningococcal and Tdap for 6th grade entry and higher. And then this last slide here is the vaccination. It's the adult vaccination coverage, and adult vaccination coverage has always been lower than the childhood and adolescent rates. This slide shows that we're fairly similar to the national rates, but in general, it's always been lower than the childhood and adolescent coverage rates. So let's move on to the meat of the presentation. This is where I love to spend time and answer any questions that you may have, because we do get a lot of questions, and rules do leave a lot of room for misinterpretation. And so I'm hoping today I'll be able to clarify any questions that you may have. New Jersey has 2 immunization regulations that have specific requirements. One is for schools and the other is for higher ed. The 857.4 rules establishes minimum immunization requirements for attendance in New Jersey schools, whereas 857.6 establishes uniform requirements for attendance at higher ed institutions. The one thing we have to keep in mind is that our goal, like I said before, is that to keep vaccine preventable diseases out of our schools and college campuses by achieving herd immunity. So those who cannot be vaccinated are protected while they are in a congregate setting. And also note that New Jersey rules has established minimum immunization requirements, and but the DOH does encourage students and collegians to receive all age-appropriate vaccines and doses recommended by the ACIP, or the Advisory Committee on Immunization Practice, for optimal protection. So this slide here shows the chronological implementation history of New Jersey's immunization school and higher ed rules. For most of this presentation, I'm going to focus on the school regulations, but I wanted to share this with you just so you understand like what New Jersey requires in both settings in schools and also in higher ed. So immunization regulations were first implemented statewide for child care facility and schools, inclusive of preschools, in September of 1975. The first vaccines required for child care and school attendance was DTaP, polio, measles, and rubella vaccine. The last time new requirements were added for schools was in September of 2008, when we added the flu and pneumococcal requirement for child care preschool and Tdap and meningococcal requirement for 6th grade and higher. Most recently, for higher education, the rules first came into effect in September of 1990 with 1 dose of a measles, mumps, and rubella vaccine requirement. And then most recently, June of 2020, we updated the meningococcal vaccine law. Actually, we amended the meningococcal vaccine law from 2005, September of 2005, to make it a requirement for all newly enrolled students attending an institution of higher ed to receive 1 dose of meningococcal vaccine between 16 to 18 years of age. So that is a change. Before, it was just a requirement for those living in campus dormitory, as you can see in the September 2005 tab here. But for the June 2020 law that was passed and amended, that was passed, because it amended the 2005 law, it is now a requirement for all newly enrolled collegians. And so it's not based on whether you're living in campus housing or not, just to keep that in mind. We are also currently going through rulemaking for all of NJAC 857, which includes the communicable disease rules, NJIAS, school and higher ed rules, along with TB. And as you can see here on this slide, New Jersey regulations are not updated as frequently as ACIP updates their recommendations, which may end up resulting in a misalignment with the current recommendations. So I'll give you an example. When we first proposed the flu vaccine requirement in 2005, the ACIP recommended all high-risk individuals to get vaccinated, and who they considered to be high risk is the elderly population and the child care preschool age children between 6 through 59 months of age. So when our rules were adopted in 2008, that was the requirement for all children in child care preschool between 6 to 59 months of age to receive 1 dose of flu vaccine by December 31st. However, since then, the ACIP has updated their flu vaccine recommendation. I believe in 2009, they changed it from 6 months through 9 years, then later on to 6 months through 18 years. And then New Jersey's rules were, then 18 years, sorry. And then New Jersey's rules were capped at 59 months of age, even though ACIP changed their recommendations. So you can see the misalignment here, where you can have a 55-month-old sitting in a preschool setting preschool sitting next to a 60-month-old, yet the 60-month-old did not have to be vaccinated or did not have to comply with the requirement because the rule language did not reflect anyone older than 59 months of age to receive the vaccine, which made absolutely no public health sense. But that's the limitation that we have currently with the rules. When we go through rulemaking, we're looking to change this because we don't want to have any artificial gaps that were created as a result of the rule language that was in place back when the rules were first proposed. So we are going to be directing, our rules are going to be, not directing, but referencing all ACIP recommended vaccines. So we'll always stay current with whatever the ACIP recommendations are. However, I just want to clarify that we are not adding any new vaccine requirements for school attendance for the 24-25 school year. But we are going to, and I'm sorry, you know what? Actually, these rules are not going to be implemented until the 25-26 school year. So again, we're not adding new requirements, but we are trying to remove any artificial gaps that were created, and we will be referencing ACIP at all points. So hopefully that will address some of the issues that we're seeing now. And so back to this flu vaccine, like again, once that does happen, there will be no age limitation as a qualifying criteria is the attendance at a child care preschool facility. So everybody 6 months of age and older enrolled in a child care preschool facility will be required to have 1 dose of flu. Okay, and I know we're spending some time on this slide, but I just wanted to take this opportunity to provide you with a little background on the legislative process in New Jersey. Rules can be made through the DOH's regulatory process, or it can be statutorily initiated through legislation. Requirements that are initiated through the department's regulatory process may be updated through rulemaking. However, if they're statutorily initiated, then DOH can promulgate rules to enact the statute. But however, DOH is bound by what the statute allows. So this too can result in requirements that are misaligned with what the ACIP recommends. And requirements that are initiated through statute cannot be changed and must be repealed through the legislative process. I have a lot of issues in my higher ed regulations because most of my higher ed rules were statutorily initiated, and there's a lot of discrepancies, and because of the time frame of when the rules, the requirements were made, they had separate statutes and the language was different, so it wasn't consistent with what the requirements were for MMR and when Hep B and Manage statutes came about. So I'm hoping that we're able to repeal some of these statutes so we can have some consistent language across the board. And this slide here is illustrating the current vaccination and dosing requirements we have for school and higher education. I know for in the essence of time, like I will not be going over each of the individual vaccine requirements. I'm going to go over the main provisions of the regulations, but I just want to take some time now to just discuss a few points that you want to keep in mind. But one thing to keep in mind is whenever I've listed 4 or 5 doses for DTaP, polio, or Hib PCV, it's all based on the earliest age at school entry. So if you think about, like, I'll give you an example for DTaP. The CDC recommended schedule recommends getting the DTaP at 2 months, 4 months, 6 months of age, 15 to 18 months of age, and then a dose between 4 to 6 years of age. So depending on when you started school, so the requirement is all based on the earliest age at school entry. So if you start school at the age of 3, or let's say pre-childcare at the age of 3, then you will need to meet the minimum requirements of having the 4 doses of DTaP at that time, because the recommended schedule is 2 months, 4 months, 6 months, 15 to 18 months. So that 3-year-old will need those 4 doses at that time. And then when they go on to kindergarten, they'll receive that 4th birthday booster dose once they come into kindergarten, making it 5 doses total for that child. However, if mom and dad decided not to send the child to childcare or preschool, and they started the child in kindergarten directly, then if they want to do the bare minimum, they can get away with just the 4 doses, as long as they have a minimum of 1 dose on or after the 4th birthday. So hopefully that makes sense. Same applies for polio, and for Hib and pneumococcal, there's minimum requirements if you're between 12 to 59 months of age to have at least 1 dose on or after the 1st birthday. So again, this is just a snapshot. If you have any specific questions on any of these requirements, I'd be happy to answer those questions at the end of this presentation. And lastly, kindergarten, just wanted to mention, we require the 4th birthday booster doses for DTaP and polio, the 2nd MMR, varicella 1 dose, and for the first time where hepatitis B is only a requirement for kindergarten, not for childcare preschool. And then, like I mentioned before, at 6th grade, we have a Tdap and meningococcal requirement. And then for our higher education, we require 2 measles, 1 mumps, 1 rubella. Hepatitis B, you may have 2 or 3 doses, depending on if you received the 2-dose adolescent vaccine, which is Merck's Recombavax vaccine, that you may get between 11 through 15 years of age. Otherwise, you would get the 3-dose series. And then we have a 1-dose requirement for meningococcal vaccine for students 16 through 18 years of age. So let's move into the actual school regulations. The rules apply to all children attending any public or private schools, including religious affiliated schools, childcare centers, preschools, or kindergartens in New Jersey. And compliance is expected on the first day of in-person school attendance. We are not providing extensions or waivers. Schools, one thing to keep in mind, and I know Department of Education has highlighted this over and over again, is that school districts may not deny enrollment. However, attendance can be deferred until the student complies with immunization rules. So we're not asking any student to be disenrolled. They can certainly enroll, but they do need to satisfy or comply with the New Jersey state immunization regulations to be able to continue attending school. Also note, the provisional admission should only be granted to children who meet the provisional definition, and I'll go over the provisional definition a little bit later in the slides. And then religious or medical exemptions are still allowed. I believe there's a lot of confusion whether if somebody has a religious or medical exemption, should they even be allowed in school? But by law, we allow the exemptions, and therefore they're allowed to remain in school as long as they meet the requirements that are set forth in the regulations. And just before I move on, just to suggest some best practices to ensure that a child's education is not disrupted because of a lack of documentation or compliance with the requirements. We know that back to school time is a very busy time. And so we want to make sure that as soon as you find out that you have a new student that's enrolling, to make every effort at that time to review their immunization records once they register, so that if you know that they are in need of resources or we need to help facilitate appointments for them, we can do so at that time as opposed to during the back to school time, because that is a busy time and they may not be able to get appointments right away, or they may not be able to get appointments, or if the provider runs out of vaccine because it's been allocated to a certain number of patients, you want to make sure that we don't run into that scenario. So It's best that we try to look at these records as soon as we're able to determine that they're enrolled, and give them a heads up of where they can go and get the vaccine if they need it. So if it is a child who's uninsured or underinsured, letting the parents know that the VFC program, we have VFC providers in the state of New Jersey, and then looking on the VFC website to see where these providers are located, we can help them get an appointment with one of them. So then by the time September comes around, then the schools can just focus on reviewing the record to see if anything's been missed and anything has to be followed up on. And then hopefully by the end of September, like all of the deficiencies or any discrepancies are resolved. So that's what our goal is. Let's move on. This is, I'm just going to bring all of this up. With religious exemptions, we allow two types of exemptions. New Jersey allows two types of exemptions: religious or medical. Philosophical, moral, or conscientious objections are not acceptable. With religious exemptions, a parent or guardian must provide a signed written statement. I know there's questions about, can a statement be typewritten? Can they send it via email? But our goal is to make sure that we don't know if somebody's sending an email, who the person is, if they're misrepresenting themselves as the parent or guardian, utilizing their account. Like, we just want to make sure that you have a signed written statement. Even if they email it to you, we would prefer that the signature be handwritten. And so in the new regulations, the new proposed rules, we're clarifying that even more, that it has to be handwritten. But just I wanted to answer that question. Also, religious affiliated schools have the ability to grant or deny religious exemptions, because nothing in the religious official of the school may state that there's nothing in their beliefs that conflict with receiving immunizations, and therefore they're not going to allow anybody with an exemption to be in their school. And they certainly have the right to do so if they choose to. Or they may make an exception because they know that not everybody of their faith is attending their institution, and so they may make exceptions. So regardless, if a religious affiliated school grants or denies the exemption, we, the secular health authority, meaning local and state health, cannot challenge their decision on why it was granted or denied. The other thing I wanted to mention is that the religious exemption does not have to indicate the child's religion. It doesn't have to specify tenets. It does not have to be notarized, and it does not have to be signed by a religious leader. Minimally, the word religion or some religious reference has to be included in their statement. And as long as that is included, we would go ahead and accept it. The one thing I do want to point out, there's a lot of things I want to point out, but there's one thing that came to my mind is that whenever somebody downloads an exemption from online, like sometimes it's just like a statement that's already pre-written, and all they have to do is submit their name, enter their name, and then the parents sign off on it. That will be a supplement to, and not a replacement of, the parental written statement. We want to make sure that they're not just providing a blanket statement like that. Like, we really want them to write the exemption and indicate what their religious beliefs are, and that conflict with receiving immunizations. So the other thing is that rules do not stipulate that religious beliefs have to be consistently held. So I know it was never meant for people to pick and choose which vaccines they want and they don't want. However, since we added the the child care requirements in 2008 for flu and pneumococcal, we started seeing a lot more antigen-specific religious exemptions, specifically for flu. So if that does happen, that you're getting a flu exemption, note that that will only exempt them from flu vaccine and not from all of the required vaccines. However, if the exemption is a blanket statement, then that would exempt them from all vaccines. And then so if they were to get vaccinated after the fact, then it would nullify or void that exemption, and they would be responsible for receiving everything that they were previously exempted from. Here's some other things that I wanted to mention. So yes, a parent may object to one or more vaccines. We talked about if their beliefs, a lot of times when you question why are they claiming against, if they were previously vaccinated and they're choosing no longer to be vaccinated because of their religious beliefs, a lot of times it's because they just state that it's because their beliefs have changed, and we don't have the authority or the right to challenge or question their beliefs. So we will let that be as long as the religious exemption is written in accordance with what the rules require. And then lastly, the rules don't stipulate that religious beliefs have to be consistently held. So, and that an exemption can be filed at any time. So if somebody did receive all vaccines previously and they just don't want to get those fourth birthday booster doses, or they just didn't want to get the flu vaccine, like we can't question, like if their beliefs change, like I was saying before, because like if they say their beliefs have changed, like how do we assess if their beliefs have been consistently held? Is it a month? Is it a day? Is it a year? Like you can't really determine that. And so we can't challenge them. Like you would have to go ahead and accept it. So the religious exemption rule is really broad in nature. And unfortunately, families are utilizing this exemption more as a conscientious or a moral objection or a philosophical objection more than it is a religious exemption. But again, we can't do anything unless someday we remove all non-medical exemptions in New Jersey. So with medical exemptions, it's pretty straightforward. It has to be written by a medical doctor, doctor of osteopathic medicine, or an advanced practice nurse licensed to practice in the United States. The exemption must indicate a specific period of time that the contraindication is valid for. And those reasons, or as I mentioned, the contraindications must be enumerated by the Advisory Committee on Immunization Practices. It cannot be a blanket exemption unless there was like an anaphylactic reaction to a particular vaccine. You can't just state that my patient has multiple allergies, therefore they won't be receiving any vaccines, because our next question would be, well, what kind of allergies and what does that have to do with what vaccines are required? So you would have to indicate the contraindication for each vaccine that cannot be given, each vaccine that is required that cannot be given, and what that time frame looks like for each of those respective vaccines. So if you're on like steroid therapy for some time, then certainly you can indicate that they won't be getting it for that period of time, but then soon after that time frame is up, you would be responsible for receiving those vaccines. Now, if after the time frame is up, you still have a current contraindication, then we would just ask that you provide a new medical exemption. So we do ask schools to review those exemptions on an annual basis. They don't necessarily have to be renewed annually, but they do need to be reviewed annually to make sure that the time frame that's listed is still current, and if they need to update the exemption. So because so many questions we receive on what's considered a valid contraindication, I'm not sure why this is shown twice, because we get a lot of questions on what's considered a valid medical contraindication. The department developed a medical exemption form in 2019. This form is accessible at the website listed at the bottom of the slide. Currently, this form is not a mandate, but rather a tool to help determine the validity of a medical exemption for mandatory immunization. As long as the form is completed in its entirety and it's accurate, then you can go ahead and accept it. Of course, if you have your own way of tracking medical exemptions, you can certainly do that as well. But a medical note or some kind of letterhead or something would be needed. Right now, this form, like I said, is not mandatory, but in the future, we are looking to make mandatory for any medical exemptions to be supplied through this form. So let's move on to provisional admission. There's a lot of confusion on who's allowed to remain in school on a provisional basis. So first thing is that in order for a student to be provisionally admitted, he or she must have at least one dose of each required vaccine and must actively be in the process of receiving the process of completing the series as rapidly as medically feasible. And I wanted to just point out, I think a lot of times people are focused on just the first bullet, meaning having at least one dose of each required vaccine. But they need to also be mindful that it's a two-part statement, that they also have to be in the process of receiving their series as rapidly as medically feasible using the CDC catch-up schedule. So in essence, like let's see, I'm going to use DTAP for an example because we have a little snippet here of the catch-up schedule for DTAP. If let's say you have a 5-year-old child who attended kindergarten, who's starting kindergarten, and they're missing vaccines, they've only had one dose of DTaP at the age of 2 months, but now they're 5 years of age. If you see here, between dose 1 and dose 2, right here, so between dose 1 and dose 2, the minimum interval is 4 weeks. And it's been the first dose was given at 2 months, but now this child is 5 years of age. Well, we know that that child is way overdue for the vaccine. And so because they're overdue, we would not allow this child to come into school without having the second dose of DTaP. So once they get that second dose of DTaP, they're considered to be back on schedule, and then they would receive the remaining doses per the remainder of the catch-up schedules, whatever the catch-up schedule stipulates. If they work, like if they, let's say they just received the first dose of DTaP like 2 weeks ago, then if the minimum interval to the second dose is 4 weeks, then we're not going to keep this child out of school because they medically can't get it any earlier. So you do have to wait those 4 weeks before they can get that second dose. So hopefully that makes sense. And so once they follow through, like you just keep following up on the child until they complete the series. So if a student is considered, a student is considered out of compliance if they don't have an immunization record or have a valid medical or religious exemption on file, or if they don't meet that provisional definition that we just reviewed. So in order for these children to be in school, they must receive one dose of all the required age-appropriate vaccines and must be on schedule to receive the remaining doses. Otherwise, they are considered out of compliance and they cannot come into school until they receive those next doses. We have 2 grace periods in our regulation. One is a 30-day grace period and the other is the 4-day grace period. So let's talk about the 30 days first. The 30-day grace period applies only to out-of-state or out-of-country transfer students. And those students are allowed up to 30 days. So we say up to 30 days if acceptable evidence of vaccination is not available. And I wanted to just mention that I think the 30 days is also misinterpreted. The 30 days is not to assess compliance, but it is to assess if somebody has vaccine documentation. Like you need the evidence to be able to determine, do they have what they need to be in school? So once the record is presented to you within those 30 days, then you'll then assess, do they meet all of the requirements for attendance, or do they have at least one current dose to be admitted provisionally? If not, then you would follow the provisional admission, the catch-up schedule and have them receive their next doses and then admit them provisionally thereafter. But if after 30 days, like if they don't present the immunization documentation, then they would have to be excluded until they receive one dose of all of the required vaccines and are on schedule. The one thing I wanted to mention here is that you can have 2 students coming from out of country, and like, let's say one student presented an immunization record, but they were missing vaccines, and another student had no record, and they said they were trying to obtain it for you. So by law, the latter student is allowed to remain in school for the full 30 days without any documentation, whereas the first student, now that you have the record and you're trying to assess, do they meet that provisional definition, may not be meeting it because they're missing vaccines. And so the question I receive most often is, well, can I keep this child in school? And so I just wanted to clarify, I'll leave it up to the school district and the local health departments, just because you would know your population the best. And sometimes it's easier to keep a child out of school and then have them comply and get what they need before they're able to come into school, rather than having them come in and then having to exclude them after the fact. Because our goal is not to keep a child out of school unnecessarily, and we want to keep them learning. And so the flexibility that the Department of Health offers is that the child who's missing vaccines, why not identify what doses are needed? So at least during that 30-day time frame, they can at least maybe go and get those doses, or they can at least have an appointment slip, because we would accept appointment slips as long as it's within a reasonable time frame. I mean, because this child could have easily, the family could have easily waited till day 30 to present a record to you, and they would have been in school anyway. So why not give them the family the benefit of the doubt and say, thanks for giving me this record on day 1. I see you're missing vaccines. Let's get you set up with some appointments so you can go and get those doses. So we want to make sure that we're working with the families and getting them what they need, so we don't disrupt the child's education. We also have the 4-day grace period, and what that is stating is any doses given less than or equal to 4 days before either the specified minimum age or the dose spacing interval, it shall be counted as valid, and revaccination would not be required. The reasoning behind the 4 days, and I'm not sure if everyone's aware, is that from the studies, from what I understand, when studies were done to see if a vaccine was administered outside of what the minimum age or the minimum interval was, would it still be efficacious? And the results, the studies show that vaccines that were given within 4 days were still showed immunity. Like the child still, the person still had immunity, but anything 5 days or greater was questionable, and so therefore that is why it was capped at 4 days. Anything 5 days or greater is questionable, and therefore would need to be repeated. But you'll have families that will challenge you, saying it was just 4 to 5 days or 6 days or 7 days. But just to know that that is the reasoning behind that, is that we want to make sure that the child is optimally protected and they have immunity. I won't spend too much time on these next 2 slides. This is just a flow chart showing, whether you should, a student may attend or be provisionally admitted, or if they have to be, or if they cannot attend, if they have an immunization record. So you would just follow along the flow chart here. And then this slide here is just for students who don't have an immunization record, and whether they can attend, or should the 30-day grace period be applied to them. So these resources are on our website, and you can take a look at them. I do have the website listed on the resource slide at the end of this the slide deck. As a reminder, immunization records must be presented on the first day of school or at the time of registration, and any updates to the immunization record must be provided to the school as they continue to receive their vaccines. And one thing I wanted to mention here is that it is the responsibility of the parent or guardian to have the immunization record translated if it's in a language other than English, for schools to be able to determine if they meet the New Jersey requirements or not. I know the Department of Education puts the responsibility on the schools to have to determine or have to get the records translated, but again, we wanted to clarify that, and in this, I think I may have taken it out, but we clarified that in our frequently asked questions, where as the translation may occur, but the translation can be made by anybody, as long as it doesn't have to be a healthcare provider, as long as you have the name and the signature and the date of the translation, you can go ahead and accept it. So we're not waiting for a child to have their records translated for a long period of time and keeping the child out of school unnecessarily. One thing here I also want to mention is the official record should have the month, day, and year listed ideally, but if only the month and year is listed, then we want to make sure that as long as you're able to determine that the minimum age or the interval was met, you can accept it. So for example, MMR vaccine given to a child who was born, let's say on May 15th, 2023, the child was born May 15th, 2023, and child received June, let's say June of 2024, they received their MMR vaccine. In that scenario, we would not accept it because we don't know if it was given on or after the child's first birthday. We don't know if it was within 4 days of their first birthday, so we would not be able to accept it. But if it was after, so after June 15, let's say it was July 15th, then in that instance, we would go ahead and accept it because we know it was after the first birthday. Official records are acceptable from the following. We accept it from schools, public health departments, colleges, our IIS record, also for military and armed forces. And the acceptable documents currently are the official New Jersey records, which are the IMM-8 card, which is it's our yellow card, also known as the standard school and child care immunization record. The Department of Education's A45, which is the health history and appraisal form. And also our official immunization record from NJIS is acceptable. And then any other electronic records currently would be considered a supplement to and not a replacement of the official New Jersey state record. However, in future rules, if they do get adopted the way we proposed it, we're looking to, because more and more schools and individuals are moving toward, or businesses are moving towards electronic records. And so we want to make sure that that is also being captured in. And so we proposed that language in the rules that other records be accepted as well. We talked about a little bit about foreign records and translation, but I just wanted to mention here that they should be, you can accept them with proper written documentation. Ideally, should have a seal or a stamp, or at least signed and dated by the physician or healthcare official. Match them up with US requirements, and you may revaccinate, which may be simpler, or you can do serology when it's possible, because we know that not every vaccine will have a serology test available. So the ones that are available that are accepted, I should say, is for measles, mumps, rubella, hepatitis B, diphtheria, tetanus, and varicella. Serology should not be done in lieu of aborting the vaccination series, and we don't have a serologic test that exists for meningococcus, or for pertussis, Haemophilus influenza type B, and pneumococcus. And the copy of the lab test must be in the student's record. However, if you don't have the lab record, you can also accept a note from the physician or the healthcare provider indicating that the child is immune, or whatever the lab values are. It can be quantitative or qualitative. So we can go ahead and accept that as well. New Jersey, I mentioned this earlier about having our we have reporting requirements for schools that they have to annually submit the immunization status report. I usually mail out those packages by the end of November, early December. It's looking at a snapshot in time between September through December 31st of the immunization status for students between September through December 31st. And they would have to submit the report to us at this link here during the reporting period, which is January 1st to February 1st. Currently, this report is due February 1st, but again, with the proposed rules, we're looking to move that time frame up to most likely December 1st. It looks like we are the only state that I am aware of that is giving so much time for children to have to come into compliance. Technically, they should be in compliance prior to school attendance. And so if right now we're giving them without having any follow-up, like from September all the way through February, where children who are missing vaccines are having the ability to go and get those doses. And we want to make sure that they have them from the time that they enter school, and only following up on those individuals who are truly provisional. And lastly, like any violation to the New Jersey State Sanitary Code, whether it's allowing a child in school without proper immunization documentation, or if they're not reporting, submitting the annual immunization status report, any of those violations are considered a separate offense and may be punishable by a penalty of not less than $50, not more than $1,000. This would usually, the local health departments would enforce the violation statute, and they would collect those fines. They would take you to the local court in their jurisdiction, and then be able to assess those fines there. Usually this may occur if you're egregiously in violation. And if you think about separate offense, that could mean per child, at least for vaccination, that could mean per child, per day, per vaccine. And so those fines are not collected from the families that are sending their children, but the schools and the child care facilities that are allowing these children to be in school without proper documentation. So, I want to make sure that I emphasize that we want to make sure that we have proper documentation in place, whether they have the requirements or not. Making sure if they don't have them, Is it because of a religious or a medical reason? Then make sure those exemptions are on file as well. Otherwise, just let's get those children up to date on the required vaccines and make sure that they are truly a provisional student to continue attending school. And then the last few slides here are just to discuss some of our immunization initiatives and resources. On this slide, we have, the department has initiatives to promote vaccinations among different populations. The first little image here on the left is our New Jersey College and University Flu Challenge. We have our New Jersey Influenza Honor Roll that is open to community partners, businesses, schools, colleges, and so forth. We also have our New Jersey Hot Shots for Tots immunization campaign, which is geared towards child care and preschool providers who, because we understand that, they may not have a clinical background, and we want to make sure that we empower them with the right tools to be able to accurately assess immunization compliance and understand what to look for in a record. And so we've developed point-based activities where they can choose those activities and then add those points up to essentially be identified as a gold level, silver level, or bronze level awardee. And then lastly, on the bottom here, we have our Protecting the Three immunization campaign, which is our adolescent immunization campaign that promotes our 4 adolescent vaccines. That's why we have 3+ here. It's HPV, Tdap, meningococcal, and also influenza. That campaign we just completed that campaign this last month, in May, and then we'll be kicking it off again in the fall. So definitely be on the lookout for that, along with our Hot Shots for Tots campaign, we just concluded. Our New Jersey Honor Roll, we just identified our honorees, and then our Flu Challenge, we've also identified. So all of these campaigns have come to a close now, but definitely be on the lookout for it in the fall. All of our initiatives are on our website listed on the bottom of the slide here. And another thing that I wanted to mention is another initiative that we're working towards, or what we're introducing, is I spoke about the VFC program earlier, but we also wanted to mention that we are looking to now have a matchmaking program that links community stakeholders that need vaccination services to VFC providers. So this effort will assist schools in identifying where children can go to receive vaccinations so they can attend school and recreational activities. Schools can also partner with their local health departments or other VFC providers to offer on-site vaccination clinics. As I mentioned previously, the VFC website has all of the VFC providers listed, so definitely take a look at that. And this community collaboration and awareness is crucial for eliminating access barriers and promoting health equity and helping us increase our vaccination coverage rates. So definitely keep that in mind. And I'm going to just breeze through the next few slides. These are just resources that I wanted to mention that Jennifer Smith, our health educator, and her team have created these amazing resources for parents and guardians. We have our provider educational resources, and also I believe, and then also immunization resources for adults. So definitely, if you're in need of any of these materials, contact us and we can get that to you. Some of these tools are also resources, I should say, are available on our website. The last thing I wanted to mention here is the immunization standards. The National Vaccine Advisory Committee has 2 well-established immunization standards, one for child and one for adolescent immunizations. And one for adults as well. And based on these standards, the Vaccine Preventable Disease Program created an immunization standard guide, which providers can use as a self-assessment tool and evaluate their progress through a PDSA cycle, so Plan Study 2 Act cycle, and conducting routine self-assessments can serve as a low-cost method of continuous quality improvement for the individual healthcare provider or the team or the facility. So we are looking to do some presentation on the standards later on in the year or early in 2025. So definitely be on the lookout for that if you're interested. And that is it. This slide is just all of our resources. We have our VPD website at the top. Sorry, the Department of Health's website at the top. VPD is the second website. The IAS is our third, and then the VFC program, and then all the CDC resources that are new. So I am happy to take any questions. I know we started a little bit late, and maybe my presentation was a little bit close to the hour mark. So do we have time for questions, Leanne or Dr. Schwab?
Yeah, I think so. Thank you, Jenny. That was a great, fantastic, very comprehensive review for us on the state regulations and
Thank you.
from the Department of Health point of view.
I'll turn my camera back on. Hold on one second.
Yeah, thank you. So there's a couple of questions in the chat. I think we can take a few questions. If that's okay, Leanne. The first
Absolutely.
one came from Iris Cooney. Great presentation. And she asked if, I guess on the part of the DOH, with the universal pre-K3 and pre-K4 requirements, are there plans from the Department of Health to support school districts, nurses, families with meeting these vaccine requirements, and what will that help look like?
So with you're talking about the hepatitis B, right? Is that what she was mentioning?
Yes. And in addition, any of the immunization requirements, because the pool of pre-K3 and pre-K4 children are going to be much larger, right? With the universal coming, down the line. So I'm wondering if there's like talk or discussions as to greater support programs for school districts to meet those requirements as well.
So, I mean, as far as like we already have all the preschool requirements that you saw earlier, like those we have support for all of those vaccines. Just the only vaccine that's currently not required for preschool childcare is hepatitis B vaccine. And, whenever New Jersey, the State Department of Health considers adding any new vaccine requirements to the regulations, we go through 9 different evaluation criteria to determine do we need to add it? Because as soon as the government makes it a requirement, the families may already be getting vaccinated on their own because they're having that discussion with the healthcare providers and they're vaccinating. But as soon as you make it a requirement, they always step back a little bit saying, now you're forcing me to do it. And so I may or may not want to have it. So we tread very lightly when it comes to considering any new requirements. And also, we also look at what the current coverage rates are. So for the hepatitis B, for 3 doses of Hep B, usually the coverage rates have been over 90% for the completed series, I think by 2 years of age. So so we need to really decide, does it make sense to make it a requirement when they're already doing it on their own? Just like it is for the second dose of varicella vaccine, the same thing there. Even though it's a recommendation, do we want to make it a requirement?
Right. Exactly.
Though we optimally recommend everybody to follow the ACIP schedule, like we have to be careful on what we make a requirement. So, but through everything, I mean, the VFC providers have and if you're a VFC child, like an eligible child, then certainly they would have all of the other vaccinations that they would need for school attendance. So does that help answer those questions?
Yes, absolutely. Yep.
Okay, great.
Thank you.
Mm-hmm.
Thanks. There's a quick question here. Are records from docket app acceptable as proof of immunization?
Sorry, say that again. It was a record of the docket
The
app?
records from the docket app, would that be acceptable proof of immunization?
Yes, so because Docket works with NJIAS, Docket is pulling the data from NJIAS, and being NJIAS is an official state of New Jersey immunization record, we would accept the docket record.
I had a question regarding the religious exemptions. I know you spent a lot of time on that in the beginning.
Mm-hmm.
And you hinted at maybe eliminating it, but I guess my question really is, in the meantime, are there any specific rules, regulations, or even guidance that either Department of Health locally or school nurses could fall back on about what to do with kids who are unimmunized during an outbreak, for example, with things like masking or quarantine and things like that?
So whenever we have any cases of any vaccine preventable diseases in our schools or in our community, well, let me just speak to schools. Whether it be in a classroom, and depending on the number of cases that we have in a classroom, like the local health department would be able to, at that time, provide the guidance, because this has to be reported to the locals, and then the locals would provide the guidance as far as determining how many children are religiously or medically exempt in that class, whether it be a classroom or whether it be in a whole school, to be able to determine who's considered to be vulnerable, and then what are those next steps in informing those parents, because there is an active outbreak going on, to consider vaccination, depending on if it's a medical or religious reason, and if they medically can be vaccinated or not. Like, that has to obviously be under consideration as well. But so that guidance is provided, but it's always provided at the time when there is an actual case or cases that are occurring in the school. As far as me mentioning removing not all non-medical exemptions, that's something that is more of a, I believe it's my wish list, and just because I know that it's being abused, the religious exemptions are being abused, they're not being utilized for what they are. And they are philosophical, moral, and conscientious objections for the most part. And so a lot of states have started to remove all non-medical exemptions, like California and New York has done. Washington has removed it for MMR, or for one of the vaccines, I'm not sure. But that would be something, that would be the direction to move towards. But at this time, we just have to wait and see. Unfortunately, that's not something the department would initiate. It would have to go through, if somebody sponsored the bill like they did in previous years, and we'd have to see if we get the votes on it to remove them.
Oh, okay, thank you.
Mm-hmm.
Are there any other questions anyone has? And I had one last one myself, since we have someone from the Department of Health here. Are there any moves in the works to coordinate the immunization registries across state lines to make them accessible or even integrated?
I am not an expert. Well, NJIS, though, is part of BPDP. Like, I am not versed on NJIS, like what their plans are as far as moving across state lines. Like, I know like there's some cross jurisdictional. I believe, but I may be wrong, and I can always confirm and get back to you on that. For New York and Pennsylvania to have access, but I may be wrong, so I don't want to misspeak. I can let me check on that for you and let you know. But I know I could say one thing, during Hurricane Katrina, this is, we're talking about years ago, when children were displaced and they came to New Jersey. At that time, I remember other states giving us, during that time, they gave us access to their respective registries, so we could help facilitate, because we didn't want to keep a child out of school, so we wanted to help facilitate that process of finding the records and getting them whatever they needed, if they needed anything. So that may be happening on those exceptional in those exceptional times, but I don't know what discussions are being had now for cross-jurisdictional for the states.
I'll add, just with having worked on NJIS for a little while, NJIS is sharing data with other states. COVID really prompted that to happen. It was always a wish, as you said, going back to Katrina and other hurricanes as well, where people were displaced. But it is happening. It is very slow because of the jurisdictions and all the laws. It doesn't always include all vaccines. But I believe we're even sharing with Florida now. You could quote me wrong, but I did hear that. So ideally, it would be with every state. It is not every state, but there are a good number of states that are sharing data with NJIS.
Good to know. Thanks, Leanne.
Yeah.
Thank you very much. Maybe would you mind putting your email in the chat? If anyone has any further questions, they can always reach out to you.
I can certainly do that. Thank you, everyone. Great questions.
Yeah, thank you so much for the presentation. So we're going to move on now to our second presentation, which is we have our members from Horizon Blue Cross Blue Shield, who are going to give an introduction to the Horizon NJ Family and Health Journey member programs helping to improve access and outcomes to vaccines. And so I'm happy to welcome Iris Novus Cooney, who is one of our two speakers. She initiated her clinical career in healthcare as a registered dental hygienist in 1998. Iris's experience with patient care and fueled by her passion for global public health, fostered her interest in community health science. She completed a master's in 2011 in healthcare administration and community health sciences, and she continued her health sciences work as a clinician and expanded her experience in public health research at the NYU School of Medicine, Department of Population Health. Working at NYU exposed her to a variety of population health research, specifically in community health science. And in 2015, Iris joined Horizon Blue Cross Blue Shield in the Government Program Communication and Public Affairs team as a community health educator. In this role, her focus has been on health education development and promotion initiatives. She also leads the member and community advisory councils, with the overarching objective of establishing and sustaining member and community partner relations and expanding Horizon Blue Cross Blue Shield's reach and influence on health and wellness in New Jersey. Joining Iris will be Khadija Anderson, who's an outreach and intervention manager within the Quality Management Department of Horizon Blue Cross Blue Shield of New Jersey. Khadija has 12 years of experience in quality management, performance improvement. She's a licensed practical nurse with 22 years experience, and she also has a master's in public health. In her current role, she manages Horizon's Healthy Journey team, who conduct member engagement initiatives and interventions for several lines of business in an effort to engage and educate members on the importance of preventive screenings, chronic condition management, medical adherence, and timeliness of visits. And so welcome to both of you, and we're looking forward to having your presentation.
Thanks so much, Dr. Schwab. I just want to get confirmation that everyone can see the slide, okay?
Yes, we can.
Terrific. Thank you. Thanks so much. And thanks for having us present today to speak on our collaborative work in health promotion and Horizon NJ Health member compliance in regards to their vaccinations and other HEDIS-related initiative work. So at Horizon, our mission is to empower our members to achieve their best health and with or through a lens of health equity focus. We strive to achieve this where every member has a fair and just opportunity to attain their highest level of health, right? So we too are committed to actively addressing, achieving, establishing key priorities to advance health equity across New Jersey. And as part of this collaborative effort, we look to not only partner internally, collaborating with diverse departments of different focuses, including our public health management team, quality, case management, our member support programs, but also our community, through community partnerships and coalition like EMIC, and other entities from a state, county, and local level, right? And in a cross-disciplinary way. We do this, again, through a concept of collectivism in order to achieve healthier communities. So today's presentation is mainly going to give a background as to what our roles look like and what our implementations look like out on the field, but also our integrated cross-departmental approach to supporting member support programs and outcomes. So Horizon NJ Health, again, is a division of Horizon Blue Cross and Blue Shield of New Jersey. We are one of 5 HMOs that provide the Medicaid coverage under NJ Family Care Plan, and we service all 21 counties. We are the largest HMO in the state, and again, as part of this, tremendous responsibility that we have to our Medicaid population. We tend to do this and leverage our community partnerships in order to reach our members. So we are the trusted invited guests that we, as part of our grassroots approach, where we participate in activities like health fairs and educational presentations, and it vasts, right, from school-based to the community health centers or FQHCs, to senior centers or community centers. Again, we are boots on the ground folks, trying to identify Medicaid eligible individuals and connect them to help them apply for NJ Family Care, the Medicaid program, and again, better understand what the benefits are for utilization. And the health education team creates curriculum around disease process and etiology, but we also give tools to the utilization piece, right? So it's not only, help applying and understanding what the Medicaid coverage is, but also how to use their coverage once insured, right? And how to maintain that coverage once it's in place. So, and we'll talk a little bit more as we present today, but during the pandemic, we had a huge surge of Medicaid eligible individuals that came onto the rolls, right? And during the pandemic, the redetermination piece was halted. Now with the unwinding and the redetermination back in place, folks who were new to Medicaid were not used to having to renew their coverage, meaning submitting to the state their eligibility requirements to verify that they still qualify for Medicaid, right? So let's say if they came into Medicaid, let's say during 2020, for the last 3 years of coverage since before the unwinding, they didn't have to submit documentation to maintain their Medicaid coverage. In 2023, with the unwinding, that requirement was lifted. So many folks that were unfamiliar or with that requirement, either that was new to them and the re-education on our behalf was preemptive, right? So in order to reduce the likelihood of folks losing their coverage and disruption of care, we upped the education piece through our partnerships, not only to the community, but to those providing services to the Medicaid eligible population, right? So again, we do this in partnership with you, so you too can help us with these efforts, helping identify folks who have Medicaid and ensuring that they have renewed their coverage to reduce the likelihood of medical service disruption, and also connect them to the resource to help them renew if they are unfamiliar, or again, for folks that may have been on Medicaid, and to ensure that they don't lose their coverage, just to get them that added support that they may need in order to help with the renewal process. In addition to the renewal process, NJ Family Care expanded the Cover All Kids, which includes the eligibility for uninsured children to receive undocumented children to receive coverage. So again, age 0 to 19, where they may be eligible for NJ Family Care coverage to all income eligible children in the state of New Jersey. Again, this is unique to New Jersey. Not every state provides this. We are really fortunate that they have included this benefit to all children in the state. And again, this also helps with the efforts in getting compliance with HEDIS-related gaps, right? So once children are enrolled in school or at any age, hopefully we can get them before they start school, but at any rate, if there's a child that is a resident of New Jersey and they may be, they are uninsured, they should be connected to an enrollment navigator to help them apply. Again, and they can apply on their own through the website, but most of these families can use the help and the assistance because those applications are dense. And we are here to facilitate that process. And again, we do this in partnership with agencies like yourself. So if you do identify families that may be eligible, please connect them to us. And again, they do not have to choose Horizon just because a Horizon representative is helping them with the application. They are free to choose whichever HMO best suits them. I'm getting a bit of feedback. I'm not sure. Okay, I'll continue, but thank you. So please, full disclosure, the objective is to ensure that individuals that are eligible, that children that may be eligible apply and get the coverage if they are eligible. So they do not have to choose Horizon just because we are helping them. That's one. Two, they're free to choose with whichever HMO is best, you know, of their choice. And the second piece is to identify, you know, a medical home, right, the FQHC. So again, this in the larger objective of ensuring that children get the medical services, their vaccinations, and any early intervention services that they may need, and not have healthcare insurance or the not being covered be a hindrance of those services and compliance. So our outreach team is focused on, again, improving member health literacy by understanding personal disease risk, leveraging medical team in order to make informed health decisions. We do this through a health equity, social determinants of health lens. Our objective is for folks to get evidence-based information in a common language, culturally relevant manner, and through a trauma-informed lens, right? We want to ensure that the information is current and it's through science-based information, but again, in a relevant and digestible way. And then again, pairing it up with the supportive programs and the how-to they can use their healthcare benefit to help them maintain that health, right? So the focus of increasing health literacy and the tools for self-advocacy, right? And navigate the healthcare space. You know, even with the most well-educated individuals, their health literacy may not be at par, right? They may be subject matter experts, you know, in that space, but healthcare systems and navigating can be very heavy, very confusing. And for vulnerable populations, it could be an added barrier, right? So what we aim to do is to not only provide the information for them to make best informed health decisions, but the how to leverage their healthcare team within their medical homes to do that. And we do that in partnership with our internal member support programs, like the quality management team, in order to help the member better understand what other services and support programs are available to them to ensure that they are supported through their health journey, right? So again, and we do this in an intersection type of way, right? So we try our best to break down these internal silos as well as leveraging our partners in order to do that, lessening the burdens of emergency room utilization, and again, improving the health outcomes of our members. So with that, our quality management team has several roles and responsibilities, such as accreditation and regulatory oversight, and HEDIS performance improvement in managed care organizations. Healthcare effectiveness and data information set, otherwise known as HEDIS, is a widely used set of performance measures in the managed care industry, developed and maintained by National Committee for Quality Assurance, or NCQA. So essentially, this measure assist in measuring the quality of performance of care across all managed care organizations. And they're based on clinical guidelines and standard of care, and how our approach is to the health education team, to outreach team, to be a complement. And we design our outreach efforts to support internal quality management teams by educating on the variety of member support service programs. Part of the utilization, navigation, and health education team provides an in-depth ideology while including how to access and leverage health promotion support programs. And with that, I'll turn it over to my colleague, Khadija Anderson, to talk about the quality management team's interventions.
Thank you, Iris. Thank you, everyone. Thank you for giving us the opportunity to present today. I'm Khadija Anderson. I'm the Quality Management Manager for member engagement, essentially, basically. So Horizon Healthy Journey is our member engagement section. We also have a provider engagement that's considered, they're called results and recognition. Today, I'm going to present on Horizon Healthy Journey, the member engagement portion of our quality management and how we reach out to our members. So our Horizon Healthy Journey program helps provide quality of care and improve healthcare outcomes for our members. We focus on the importance of preventative health screenings, medication adherence, and timeliness of visits through education and engagement with our members. The program was launched to improve HEDIS and STAR rating, quality performance via population health management. I'm going to continue here and then I'll go in further detail. For the Healthy Journey program, we offer support through 3 various areas. We have personal touch, and throughout the year, we have a team of 4 quality outreach coordinators that actually are responsible for operating our Healthy Journey line. And essentially our Healthy Journey line are one-to-one calls where members can call in. And if they have any barriers that they're facing pertaining to any of their preventative screenings, if they need any assistance with speaking with Modivcare. Modivcare is our vendor that's assigned for transportation. If they need help changing doctors, any of those 3 areas, and much more as well, my 4 quality outreach coordinators are responsible for. So we conduct one-on-one calls to provide health screening reminders. In addition to that, we provide health education and information on chronic disease management. In addition to our calls and our call line, we also have our health mailers that we provide health education on, some of which you just were able to see, and I'll have I'll have Iris go back in a second just to review some, and I can go in further detail about it. We also provide automated calls. Automated calls, they're also known as IVR calls, interactive voice recognition calls, that we provide for a lot of our measures. And when I say measures, they're quality measures that are listed within the HEDIS program that Iris just made mention of earlier. For HEDIS specifically, it's a project that all health plans are responsible for. All health plans throughout the United States are responsible for. That's their way of rating health plans. And within HEDIS, we have over 92, close to 100 measures that are based off of clinical guidelines, as Iris mentioned. And these particular measures, they rate utilization, they rate preventative screenings, they rate our providers on the type of care we're giving for chronic conditions. So as a team for quality management, we're responsible for assisting our members or educating our members to make sure that they are taking advantage of their health insurance and going in for these types of screenings and managing their care. Moving on to awareness, you know, with all of the interventions that we're doing, as I mentioned before, we do use data-driven approach to tailor these educational materials on health screenings and education that our members need to actually know about, right? So we provide that awareness through all of those components and interventions that I mentioned previously. We also have a rewards and incentive program that we also use to help engage and incentivize our members. So it's one thing to educate our members to, you know, the importance of healthcare, but we also want to incentivize them to make sure they're taking their kids in for well child visits, lead screenings, prenatal and postpartum, which is specifically for birthing individuals that are members with us, right? So we have a various programs that we have, and some of them I just mentioned here. So it's one thing to do interventions, right, that I would like to go over in a second, but I also wanted to share the process. So we do interventions, but we need to make sure that they're effective. We need to make sure that our members are understanding what they're receiving. So I'm willing to share that process with you in the next slide. Iris, next slide, please. Okay, so I've listed, you know, I simplified it here, our process. Some of the implementation of our interventions, as I mentioned, we use one-to-one calls, outreach to our members, personal outreach. We also do the health mailings to our members. We do the IVR calls. In some cases, we work with vendors to help with care coordination. Not so much for the pediatric population, but in the chronic conditions population. So as I mentioned, once we do these interventions, we also look, which is a very important part of our process, is to then look at all of our interventions throughout the year and look at the effectiveness, right? In the case of Medicaid, what I didn't tell you before, Horizon Healthy Journey is responsible for all lines of business for Horizon. So although we are mentioning, you know, referencing Medicaid here, we're also responsible for SNP. We're also responsible for Braven Health information as well, commercial and so forth. For these purposes, I know you guys are aware we're talking about Medicaid. So for the Medicaid interventions, and specifically our Medicaid population is large enough that we have to divvy it up among two specialists. And so we have a specialist that's responsible for the adult population, and then we have a specialist that's responsible for the pediatric population. So once our interventions are completed, ideally, we typically wait about 60 to 90 days out after the intervention, and we conduct an impact analysis for each of our interventions. We typically do about 60 days, and that account for, you know, time with claims and and providers sending in their bills and so forth. We look at the impact, look at 60 days out to see if our intervention was impactful in having the members actually close their care gaps. We call them care gaps. Now, there's not 100%, you know, that's not 100% a way of saying that you know, due to this intervention, the member actually closed it. It can be due to other things. They could have went to their doctors, the doctors could have educated them, but that's our best way of actually determining if our members, you know, if they received it, and as a result of receiving it, let's look 60 days out to see if they actually closed the care gap. So for all of our interventions for pediatrics, we look, well, for all of our interventions in general, but for pediatric, for this purposes, we look 60 days out. The purpose of this particular impact analysis is to, one, check and see if our interventions are effective. And then two, we also get together as a team. I recently, I want to say about two weeks ago, we met as a team, a larger team, to actually go over it together, right? And once within our impact analysis, we also compare it to the year before. So if we've done a similar intervention for the year before, we compare this year's intervention with the year before to see if there was any improvements, or if there was, was a decrease also noted, because then we then go back and look at the interventions that said, okay, what is it that we maybe did not mention, or that we did mention that is causing, that could be possibly contributing to that increase or the decrease. So that's the purpose of it, is to look at the effectiveness and then make those changes for the year to come, right? So that's something that's going on. I'm not sure if I'll have enough time, but if we do, I will definitely just give you an example. I didn't want to copy and paste it here because that's proprietary information. I can kind of show you a glance of it if I'm able to share the screen after this presentation. Moving on from the impact analysis, we also monitor our rates on a monthly basis to see if we're making impact within our HEDIS rates as a team overall, and as a plan overall. Because with us monitoring, we can see if our interventions are having impact on our rates. And if it's not, we might need to pivot. We may need to end this intervention, try something new, and to focus on those rates. In addition to focusing on those rates throughout the year, we also focus on our state work plan that we work with DMOS on throughout the year, to make sure if there's any interventions that we have, or not interventions, any measures that are falling below the 50th percentile actually falls onto this work plan. And we want to make sure we are driving those into not our interventions, but our measures up throughout the year. So that's our monitoring HEDIS rates. In addition to that, we also conduct HHJ, which is the Horizon Healthy Journey member survey. We do that at the end of every year for each line of business. And these are just some of the questions we ask. I did copy and paste some of the questions that we ask our member. So it's really important to us to, once again, implement the intervention, look at the effectiveness, and then we need to ask our members, is it effective to you, right? So we do a random selection for each line of business every year, and we do IVR calls to our members to ask them these questions and have them rate them and give us their feedback. Some of the questions that we ask are listed here. Have you found the Horizon Healthy Journey health education mailers and reminders to be informative and helpful? We also asked, have you found the Horizon Healthy Journey education mailers to be easy to read and understand? Additional question is, have you found the Horizon Healthy Journey education reminders effective, useful, and prompting you to take action? In addition to that, we have the Horizon Healthy Journey staff that I mentioned that operates our Healthy Journey line. So we asked them, did they find the staff to be courteous? We also asked, did they find the staff to be able to answer their questions and resolve their problems? And to be quite honest with you, a lot of our responses have been over 80%. So I'm really proud of my team, which I have expressed to them a few weeks back. In our rating, we also asked them to rate the whole program. The whole program is composed of not only the telephonic side, but also the interventions and the mailers that we send out throughout the year for different measures. I think that basically summarize it, but there's two areas, if I'm allowed to do so, that I would like to go over. We also have a rewards and incentive program. We actually have a meeting going on about that at the moment. So we're trying to get that up for July for our immunization population, for our immunization and our PPC population. So we combined those two programs, and we're incentivizing the maternal population. At this present time, we're working on that to incentivize them to go in for their prenatal care. We want to make sure that the members are informed of the importance of it. So we're incentivizing them with $30. This program is not up and standing just yet, but hopefully by July it will be completed. We're working on the planning phase right now. But we have prenatal care visit that we're incentivizing pregnant individuals to make sure that they're informed of the importance and make sure they're going in for their prenatal care visit within their first trimester. We're also incentivizing them with $30 gift card for postpartum care visits. So after they actually have delivered, we want to make sure that they're going in for their postpartum visit between 7 to 84 days after delivering their child. In addition to that, we are also incentivizing the parents of kids to make sure that they're taking in their kids for well child visits between the ages of 1 to 6 years. And we're incentivizing them with $10 per visit with a completion of 6 visits, totaling $60. And we're also incentivizing parents of kids for lead screening. So lead screening is an area that we continue to battle with across, New Jersey, not only us, but other MCOs as well, making sure parents understand the importance of it. And we are providing parents with $25 gift certificate upon the completion, if they had their child complete the lead screenings. So those are just a few things that we're doing. Iris, if you don't mind just going back about 2 slides ahead of this. I just wanted to give examples. Yep, one more time. Thank you. Okay, so this is just a few, but we have a much more mailers that go out to parents. This first mailer is just a reminder to parents about the schedule of well child visits, how often their child should go in and on what particular month that their child should be going in. And we give them information on what they can expect to be completed and assessments that they can expect to be completed during the visits. And that QR code actually is a QR code for immunizations and so forth. The next one over is just a snippet from our monthly birthday cards. So we decided to do a birthday card for every child who is turning 1 year. So this is specifically for a child who's turning age 1. We send this to the mothers, or not the mothers, but the parents, I should say, of the kids that are turning 1, and we tell them what's expected during this age. So we congratulate them on the child turning 1, but what else is still needed related to health for that child and how they can reach out to us if they have any questions. We also have for this intervention for 3, the third intervention we have listed here is just a reminder. This is actually a reminder to parents if their child is due for a well child visits, and we can see that their child is due, and we're reminding them that these are the expectations, and that they also need to take their child into the dentist, because sometimes the dental area is a part that I find that a lot of parents are not always aware of, that their child needs to be going in, from early as age 1. Sometimes they're like, oh, well, my child just got, they just finished teething. They just have like 1 or 2, well, 1 tooth or 2 teeth, but we have to still advise them on the importance of that. We also have here a healthier and happy baby, informing the parents on when they should be taking in their child, making sure the child is, once they have their child, they also need to be informed that they need to make sure that their child is insured and so forth. This is just a few. We have much more. I'm not sure if we're going to be able to share all of those, but I wanted to see if I do have the opportunity. I just wanted to show you an example of some of our impact analysis that we use. So let me see here, hold on. I also wanted to talk about HPV. HPV is very important. That's a vaccination that we are putting a lot of effort around. And even though this is for our preteens and our teenage population, I do want to also inform you that we have a lot of not incentives, but interventions around this particular immunization. And oftentimes, around the age of between 10 to 13, we have a specific letter that goes out to our parents, advising the parents that the child, the school-age child, needs to go in for their immunizations and their well child visit. And we also provide an insert for any of our children that still have a care gap for HPV. And I wanted to share that information. So let me see if I can share my screen, if I'm allowed to do so. Let's see.
Khadija, I'm gonna stop the presentation
Oh.
on my end,
Oh.
so that you can share your screen. Okay, let me just.
Okay, no problem.
All right.
If anyone has any questions, please put them in the chat. We can ask those after the presentation.
Thanks, Dr. Schwab. And while Khadija is getting that prepared, obviously, just like we intentionally work collaboratively within different departments, our focus too is to engage community members, ideally, all of our Horizon members, but collectively as a large community, how folks can leverage different members of their healthcare team, including dentists, including their, let's say, school-based counselors, school psychologists, school nurse, their PCPs, how they can leverage these folks so that they can get a holistic approach to their utilization of their benefits, their healthcare benefits. And with that, I'll turn it over back to Khadija to.
Thank you, Iris.
Yep.
Okay, so this is just an example of our HPV flyer. It's actually an insert, as I mentioned. So it's provided in addition to our letter that we create to parents of preteens from like 10 to 13. So this is just one of the HPV inserts. And we provide some of the information on why HPV is important. And as you guys may already be familiar, this is one that we have to work on because more recently, there's a lot of studies out there that even adults are now getting sick with ENT cancers, throat cancers, and so forth. So this is something that sometimes is important to express to parents because sometimes parents feel that, does my child really need this? Because they think that their child has to be sexually active now. And we have to explain to them, no, that's not the case. We are preventing for further down, in life. And so forth. So this is just an example of one. I wanted to see if I had some additional. This is another, excuse that it's upside down, but this is like a folded intervention. So this is just an example of one of our happy birthday cards. It's usually folded, so that's why it's upside down. And in the middle of it, it has the immunization schedule and some information here. I think I have a few more open, but they may not apply. Yeah, these are a few open, but they're not applying to immunization. I also wanted to share our impact analysis. So just an example of our impact analysis without going in too much further detail. These are just examples. So we go in detail. It's really thorough. Thanks to one of my colleagues on our team as well, that she is really deep into the data and is statistically, we even look to see if it's statistically significant. So it really goes in great detail. Right now, like I said, we are responsible for all lines of business. Right now, we're currently looking at Medicaid specifically, and I'm looking at the pediatric areas. So we kind of list some of our various interventions that I mentioned that we do. We have our targeted population, who we targeted, how we segmented, because we do segment to tailor that information to a specific population. When was it launched? How many members did it go out to? The care gap that we are analyzing. How many of the members, out of the members that we actually sent it to, how many of them closed the care gap based on claims? Intervention success. And then, as I mentioned before, we compare it to the year. If we had an intervention similar before, we compare it to the year before. In this case, this was like an IVR. So we didn't compare it to the year before. We just compared it to members who did not answer the IVR. We wanted to compare it and see, okay, was the members who did not answer the IVR, let's see how well did they close their care gaps. And we compared it to see how effective the IVR was. So this is the IVR situation. If we have mailers, we compare it to the year before. And then, like I said, in cases where we see a decrease, we go back and we actually say, okay, let's look at the changes. Why could we be possibly receiving these changes? Did we make a change to the mailer? That could be causing this, and then we adjust accordingly for the years, the year ahead. So this is just an example of what we're doing. And, you know, so example of our rewards program, I think I may have something here. Let me see if I happen to have something open here. Okay. So we're working on, this is the program that I told you about. This is still in the process of being approved, but this is the program that we're going to get going for July. Hopefully, we're working with the state to have it approved. And as I mentioned before, we tell the members how they can redeem after they close their care gaps. These are the different healthcare activities we plan to have the members eligible for. And not only that, once it's completed, how they can choose their gift cards. And these are some of the gift cards we're going to be offering them. So it's pretty extensive, I would say. And kudos to working with Iris and my team. My team puts in a lot of work here. So I think at this point, I'm going to stop sharing here. And I would like to open up to the team here to see if there's any specific questions that you would like me to answer.
Yeah, thank you both. That was a great presentation, really a wonderful program that you're having there at Horizon. Are there any questions that anyone has? I just had
So
one.
Dr. Schwab, so just in lieu of folks kind of getting questions, I just wanted to add that it's important that our community partners at least have a greater understanding of like the breadth of the work and what it may look like. Since you are the ones that are directly connected to our Horizon Medicaid members providing services, and can help identify families that may be eligible. So again, if you do come across families, individuals that may need assistance, please connect them to us. Even if it seems that it's not relevant to like medical services, connect them, because we may have a program in place internally that may speak to that specific need, or connect them to a resource out in the community that can further assist them in that, to address that need, right? So we do this again in partnership and with the assistance of our community partners, right, to help identify, because we can't be everywhere all the time, right? We're working with a small group. So with that, I'll yield back for any questions.
Yeah, thanks. That's great. If you could also put your contact information in the chat.
Sure.
I know I saw the last frame there had lots of phone numbers on it. If that's something you wanted to share with Leanne, she might be able to send that out as well.
Will do.
So we're approaching the end of our 2 hours. I'm going to turn the meeting over to Leanne now to continue with the working group updates.
Absolutely. Oh, thank you, everybody. So I'm just going to quickly go through the working group updates. Let's see. Here we go. So our community education working group met on May 23rd. Couple of upcoming events I do want to highlight. In September, we're going to be talking about the flu vaccine and the RSV vaccine. In December, we're going to have an in-person EMIC meeting in Irvington to talk about hepatitis B. We're in the early stages of planning it. I'm hoping there's some tabling opportunities, so more to come on that. And our own Dr. Schwab will be speaking about hepatitis B and maternal and child health there. And we also talked about some upcoming EMIC topics, and this has come up a couple of times actually, an overview of the immunization schedule. And Jenny, I know you touched on that a little bit, so that is something that we can definitely work on as well. And then, did I go back? Community education. And then also, again, getting ready for the fall. We're planning upcoming immunization clinics in Irvington, Newark, and we always plan clinics for our partnership staff to make sure they have the opportunity to get the flu vaccine. I think we're just going to do the flu vaccine. And I will share this information again we can help you spread the word about vaccinations to your community and your staff. So here's a list of presentations as we're getting ready for the fall, the busy immunization season, some presentations that we can come. We can talk about COVID, flu, RSV, a guide to adult immunizations, and we can customize presentations as well. So be in touch. Let us know if you'd like us to come virtually or in person for you. And our community engagement working group met May 30th. Just a quick overview, we have 164 EMIC meetings here. And as Jenny talked about, DOH is a wealth of information in terms of recorded webinars, immunization requirements, toolkits for parents and providers. So you can check them out here. And again, I'll share this information with you after the meeting. And as Jenny mentioned, we concluded our Protect Me With 3 contest. Here is two examples of our winners, one 7th grader, one 12th grader. I am printing out our winners, and I will be sharing posters in the community. It's a really creative way to get kids and families interested in getting vaccinated. And you can see these are evidence-based. So every poster has facts on them and directs people to the Protect Me With 3 website for more information on immunizations. And I just think our kids are so talented. They do such a great job. And then Step Up, Vax Up. And we're short on time, so I'm not going to play this, but we concluded our Step Up, Vax Up college awareness campaign. So these are New Jersey college students who had a chance to win up to $5,000 to create content to promote immunizations. You can see the winners on the Step Up, Vax Up website. We just announced that last week. Oh, and I think it's a little long. It's a little long for now, and we're running short. So let's see. I don't know if I can move forward here, but that was my last slide. So I'm gonna Dr. Schwab, I'll hand it back over to you and Dr. Sharp for our final announcements.
Okay, thanks, Leanne. And I encourage any of the members on to join one of the working groups if you're
Please.
interested, because that's where a lot of the work gets done for our coalition. With that, I'm going to wish you all a good summer, and then I'm going to turn it over to Dr. Sharp to conduct our last-minute introductions and community updates and close out the meeting for us.
Okay, thank you, Dr. Schwab. Good afternoon, all of our members of the coalition. Leanne, thank you so much for pulling it all together all the time for us. And again, I want to just ditto, yes, the New Jersey Department of Health has a wealth of information. You can always go there, as well as you can always reach out to Leanne throughout the month, and she can make all the connections for you. So at this time, because of time, I'm just going to ask anyone that has an event that's coming up that you want to share with the whole entire coalition for support, please, if you could just email that or send that to Leanne, that would be great. That would be great. And she'll make sure that everybody gets it. But I do want to ask, is there anyone new here today? Anyone new that's on the line with us today? Just send up a little hand or something, a wave. Oh,
Hi.
we at least want you to just announce who you are and what agency you are representing.
Yes, so my name is Rafia Sadiq. I am the new adolescent adult immunization coordinator at the Department of Health. So it's very nice to meet everyone.
Thank you for joining us. Thank you. Thank you. Please come back. Anyone else? Anyone else? Okay, it looks like everyone is our ongoing family here. And so without further ado, thank you all for all the amazing work you do in the community. Very much appreciated. Thanks to all the agencies. Thank you for attending these meetings, the coalition meetings. And again, any information that you have, we want you to share it with Leanne and she will share it with us. I think that's it. Leanne, do you want me to hand it back over to you or just say so long to everybody?
I think we're good. I think thank you so much. Look out for information on our September meeting and again, more information on our December in-person event. So thank you everybody for joining.
Thank you. Thank
All
you.
right, take care. Bye-bye. Happy summer.
Thank you. Bye-bye.
Yeah, bye-bye.